Everyone, good morning to everybody. Good morning, good afternoon. I don't know what time it is in your country. I'm Dr. Paolo Del Greco. I'm here just talking for my chief. There is Dr. Prof. Enrico Lombardi. Now he has got problem with the connection, so I'm just starting to introduce me and my colleagues in these three cases. So here we have the section of the IPPN clinical case, and also our in our country, our society, SIMRI is going to present also this case. Okay, we have three cases. The first one is from Giulia Canali and Michele Ghezzi. Second one, Antonella Gambadauro, sorry, and Sara Giuseppe Parisi. The third one is from me and my colleagues, Alberto Terminiello. So I think we can start if my colleagues want. And the first cases is severe asthma and not controlled with biological therapy. Thank you.
Okay.
You can start. Yeah, sure.
I share my presentation. Okay. Good morning, good evening to everybody, wherever you are. Here in Italy is almost 7 p.m. Thank you for joining this online meeting. I'm Giulia Canali. I'm glad to propose this clinical case that we faced here in Milan at Buzzi Children's Hospital. I will start presenting the clinical case, and then my pulmonology supervisor will speak in more detail about how we reached the diagnosis and how we approach the choice of therapy. So this is the case of Mary. This is a fantasy name. She was born at term via scheduled C-section due to breech presentation after a complicated pregnancy. She adapted well to extrauterine life with a birth weight appropriate for gestational age. She was formula fed and began her community life at the age of 3 by starting kindergarten. Just a quick look to her family history. As you can see here, her mother was diagnosed with ulcerative colitis and suffers from respiratory allergies with rhinitis, and also a lot of relatives suffered from asthma. Initially, Mary enjoyed good health until she began attending kindergarten. In September 2016, she began experiencing multiple infection episodes. These infections were accompanied by cough with bronchial obstruction component, shortness of breath, dyspnea, and this also led to a reduction in her gaming activities. During these episodes, her physician prescribed her systemic corticosteroid therapy, bronchodilators, with improvement. Antibiotic therapy was not necessary. In September 2017, she began a pulmonary follow-up. We made a diagnosis of asthma after, of course, carrying out all the necessary assessment. And we began to follow her by setting a prophylaxis with inhaled corticosteroids in combination with anti-leukotrienes with only minor improvement. At the age of 6, her prophylactic regimen was modified to include a combination of topical salmeterol and fluticasone. By October 2020, as you can see here, specific IgE tests revealed sensitization to dust mites and pet dander with a significant level. So environmental prophylaxis was implemented. As you can see, also IgE started increasing. Despite her initial excellent compliance with the therapy, by December 2020, frequent asthma exacerbations were reported, and consequently the dosage of salmeterol and fluticasone was increased. As we moved into 2021, it became clear that high dosage of corticosteroids and frequent exacerbation were a significant concern. So in March 2021, we decided to start a treatment with the biological drug mepolizumab. The treatment led to several improvements and also eosinophils decreased as expected. By late April 2021, prophylaxis with salmeterol and fluticasone was finally decreased. So after two years of good clinical control, something started changing. By January 2023, we repeated blood exams again, and tests indicated an increase in total IgE. So from March 2023, her condition began to worsen. As you can see here, lung function showed a gradual decline. Her therapy was increased once again. So we decided to perform a chest tomography in order to better understand what was happening. And we repeated also skin prick test that showed a new sensitization to Aspergillus fumigatus. And by August 2023, mepolizumab therapy was discontinued due to her poor effectiveness. Hospital admission was planned for bronchoscopy with bronchoalveolar lavage to search for fungal IFI, and everything was negative. So given the clinical worsening and poor disease control, we started considering the possibility of an allergic bronchopulmonary aspergillosis, ABPA, a nosological entity that complicates the clinical course and management of patients with asthma. So here you can see how over the years, the guidelines for the diagnosis of IBPA have been revised many times. In particular, the 2017 ISHAN guideline on which we based our diagnosis of this clinical case have recently been revised. Here you can see the review, and here you can see the criteria according to this very recent revision of the guidelines from this year. The first point for making a diagnosis is the level of IgE. The guidelines recommend measuring specific IgE level, but in certain circumstances, they also allow relying on the results of prick tests. And in our case, the prick tests were positive. The second point is serum total IgE more than 5,000. And 500, sorry. And this recommendation deviates a little bit from the previous guidelines where the cutoff was set at 1,000, and we have it. Then, any of two of the following: positive fumigatus specific IgE detection by enzyme immunoassay, and we don't have it. Blood eosinophilia more than 5,000, and we have it more or less. And at the end, chest tomography with a central and peripheral bronchiectasis, and we had a normal tomography, chest tomography. So what were we facing? In 2006, the term severe asthma with a fungal sensitization, SAFS, was first proposed in a review that analyzed the role of fungal sensitization in asthma. And now here we are with a 2020 review that explains the update criteria for SAFS. Here are the criteria. We had positive prick test for aspergillosis, a severe form of asthma, high level of IgE, and negative IgE for Aspergillus fumigatus. So what were we missing? And now I introduce Dr. Michele Ghezzi, that is going to present you the fascinating and interesting part of this clinical case.
Thank you, Giulia. Thank you very much. Good evening to everybody. As Giulia has already explained, Mary presented a severe asthma undergoing biological therapy and sudden worsening. We were able to diagnose severe asthma with fungal sensitization, but we wanted to verify what we might have missed. The parents had always declared the presence of a slight mold contamination, but by stressing this aspect, we were able to discover a significant mold contamination of Mary's home, especially in her bedroom, as you can see. So what could we do now? The first goal to achieve in the therapy is to reduce the fungal exposure. First of all, we suggested changing the child's room, and we activated the support of social services for the expensive renovation works needed. Unfortunately, we don't have randomized controlled trials for the treatment of this condition. The first option recommended is to optimize the asthma therapy, also with biologics. However, the therapy with mepolizumab had been stopped due to ineffectiveness, and the total IG levels didn't allow the prescription of omalizumab. The only option available was dupilumab or corticosteroids, systemic. In literature, children with severe asthma with fungal sensitization show in 33, which is upstream in the inflammatory cascade showed in the slide. For this reason, dupilumab, acting at the level of interleukin-4 and interleukin-13, may have a role in improving the control of the disease. Unfortunately, in the literature, only some reports are present about the possible role of dupilumab in the management of severe asthma associated with ABPA. Much less has been reported about the role of this biological drug in relation to severe asthma with fungal sensitization, especially in children. We need a randomized controlled trial to be able to apply this therapy to this condition instead of long-term oral corticosteroids treatment. We finally decided to start dupilumab on March, and we needed only 3 months to find a very excellent clinical response with a significant improvement of the lung function. The child, Mary, was also able to practice again sport activities with a very good control of the disease. So, what have we learned from this case? First of all, if something start worsening in the clinical course of any diseases, start again from medical history is recommended. It's very important in asthma patients to consider also home pollutants as possible risk factors. We need to consider ABPA as a comorbidity of severe asthma, but we need also to know that it's less frequent in children, and that in the differential diagnosis, severe asthma with fungal sensitization is more frequent in children. At this moment, we don't have a randomized control trial, but in the future, we hope to be able to consider biologic therapy as a treatment of this specific condition. Thank you very much for your attention.
Thank you very much, Michele. I apologize, I had some technical problems, so it was a mess for me to connect, but I did it. I've seen no questions so far, and we are in perfect timing. So I will say, let me check again. No. So I would like to remind you that if you have questions, you just have to write the question using the chat tool. So let's go again ahead here. So let me see. So we are moving to the second case. And the second case is presented by Dr. Antonella Gambadauro from Messina and Dr. Giuseppe Parisi from Catania. And the title is Not All the Wheezes is Bronchospasm. So please, Antonella.
Yes, good morning or good evening to everyone. I'm sharing my slide. Okay. Here I am. Okay. I'm Dr. Gambadauro from University of Messina. It's a pleasure for me to speak to all of you from Sicily. Dr. Manti had an unexpected problem, so Dr. Parisi will support me for the final discussion. I would like to introduce you our case about a Caucasian term-born female with a physiological perinatal period. She had normal growth and development, and she had a complete immunization schedule. From the age of 2, she had recurrent respiratory infection and recurrent wheezing. At 4 years old, on October 2023, she needed an hospitalization in a second hospital for tachypnea, fever, and dehydration. She had a radiological diagnosis of left pneumonia, and she started the treatment with oral amoxicillin and clavulanate. After 2 days, she did not respond to this treatment, so she was modified in intravenous ceftriaxone for 7 days and oral clarithromycin for 10 days, and then oral cefixime. After initial improvement, she had a re-onset of fever and tachypnea, so she performed a chest X-ray with the suspect of necrotizing pneumonia and left lung abscess, confirmed with contrast-enhanced chest CT. So she was transferred to the pediatric intensive care unit. After 12 hours from the admission, she had an acute respiratory distress, and she performed an urgent chest CT, which showed a massive pneumothorax. She needed intubation with cuffed endotracheal tube of 5 millimeters, and she started by BEP. She needed also a thoracic drainage. On the liquid, on the pleural fluid, a positive PCR for Streptococcus pneumoniae was found, and she started therapy with piperacillin tazobactam and then meropenem combined with linezolid. However, she did not improve, so she required an administration of intravenous immunoglobulin, and thoracic surgeons decided to perform subsequently left apical segmentomy and MPMectomy. She had a clinical progressive improvement, and she was extubated after 15 days. At the end of November, she was discharged to home in good condition. After discharge, her mother referred the presence of intermittent mitracheal tagging and then the evidence of wheezing. She was initially treated at home with inhaled salbutamol, inhaled beclomethasone, and oral steroid without improvement. At the end of December, she was admitted to the pediatric emergency room of our third-level hospital for breathing difficulty. At the physical examination, she had normal consciousness, no fever, no signs of active infectious disease. However, to the thoracic auscultation, there are wheezes, and she had also thoracic retractions and increased respiratory rate. The initial diagnosis was bronchospasm, and she started treatment with inhaled salbutamol every 20 minutes and then intramuscular methylprednisolone without good response. So she was hospitalized in our pediatric unit. According to her previous history, the initial investigation were various. Routine laboratory tests were normal. Immunoglobulins A, G, M, E were normal. Lymphocyte populations were normal. Serological investigations for tuberculosis, Mycoplasma pneumonia, Chlamydia pneumoniae, Bordetella pertussis were all negative. A film array on nasopharyngeal swab was negative. Cardiological evaluations were normal, and the chest X-ray did not show any active infectious disease. The treatment in our pediatric units was continued with inhaled corticosteroid, inhaled salbutamol every 4 hours, and oral betamethasone in high dose. She had a progressive clinical improvement, so this therapy was decreased. However, during her stay in the hospital, And a persistent noisy breathing was identified and was identified as a biphasic stridor. So we decided to start inhaled budesonide without improvement. So we decided to perform third level investigation. A transnasal fiber optic laryngoscopy showed a thickening at the subglottic region of the first tracheal ring. A tracheal CT showed a thin fibrous membrane in the proximal tracheal tract. And finally, the bronchoscopy showed a concentric membrane and the first tracheal ring level that caused a narrowing of 17% of the tracheal lumen with a normal caliber of the mid-distal trachea. Our final diagnosis was of post-intubation tracheal stenosis. The thoracic surgeons performed a balloon dilation and a recanalization of the 80-85% of the lumen was obtained and remain at the reevaluation after 2 weeks. The child was discharged to home without complication, and the follow-up at 45 days with transnasal fiber optic laryngoscopy was normal. So our case is about tracheal stenosis, and this is one of the most common causes of chronic upper airway obstruction in children. We can divide this condition in congenital or acquired. The post-intubation tracheal stenosis is one of the most common cause of acquired tracheal stenosis, with an incidence between 1 to 10% for operative condition. Risk factor for post-intubation tracheal stenosis include traumatic intubation or multiple intubation, incorrect endotracheal tube sites, high pressure in the cuff, unplanned extubation, prolonged duration of intubation, respiratory infection within 14 days of intubation, or individual factors such as preterm infants or low birth weight. By considering our case, we can see how the cuff tube used in our child was higher than expected for age. And she needs also a prolonged intubation period, considering her previous respiratory infection. Symptoms for tracheal stenosis are frequently misdiagnosed as asthma, and children can experience recurrent pneumonia, progressive dyspnea, wheezing, cough, and retractions. In severe cases, stridor is frequent. In 2015, the European Laryngological Society proposed preoperative assessment and clarification of laryngotracheal stenosis in a consensus paper in adults and children. This consensus proposed an endoscopic evaluation, the evaluation of the grade of stenosis based on the Cotton-Meyer classification, the evaluation of the number of the subsites involved, and the evaluation of the presence of comorbidities in children. The endoscopic diagnostic workup is based on the awake or asleep indirect laryngoscopy, transnasal fiber optic laryngoscopy, direct transoral laryngotracheoscopy, suspicious microlaryngoscopy, and bronchoscopy. All these evaluations are important to define the presence of a stenosis, its grade, its length, and to define the presence of other conditions, such as laryngotracheomalacia or vascular anomalies. Particular radiological evaluation by CT scan with or without intravenous contrast medium. It's important to define the presence of abnormal mediastinal vessel or muscles, and MRI can be used for define the presence of vascular compression secondary to cardiovascular anomalies. In the workup of these children, it's important to perform additional evaluation, such as functional assessment of respiration of voice, but both these evaluations can be difficult to perform in children. It's important to define the general condition of the children involved, such as the presence of gastrointestinal, cardiovascular, or neurological anomalies. The decision-making is often based on the grade of the stenosis, based on the Cotton-Meyer classification. So for the first two grades of stenosis, in presence of asymptomatic asymptomatic child, we can support and wait and see policy with endoscopic follow-up every 6 months. In symptomatic follow-up, in symptomatic children, endoscopic treatment can be suggested, and endoscopic balloon dilations seems to be successful in the first grade of tracheal stenosis. However, for children with grade 3 and 4 of tracheal stenosis, surgical procedures can be important. I would like to ask to Dr. Parisi to discuss about what we learn from this case. Thanks.
Thank you, Antonella. First of all, I would like to apologize because I was not the supervisor of this case, because Professor Sara Manti was the academic tutor, but due to personal reasons, she was not able to join this meeting. So it's up to me to outline the key points of this case. First of all, we should keep in mind the concept of risk awareness, because the primary lesson is to early recognize patients at high risk for tracheal stenosis, because patients with prolonged intubation or patients with improper techniques or equipment should be assessed for this kind of complication. The second point is the early recognition, because if we have a patient with a persistent cough or stridor or difficulty breathing after extubation, maybe these patients might have a tracheal stenosis or laryngotracheal stenosis, so it should be evaluated for imaging or endoscopy or bronchoscopy, for example. The third point, the importance of preventive measures, because for example, the proper endotracheal tubes in terms of measures or in terms of length, or the appropriate pressure when the patient is under mechanical ventilation, because the proper pressure minimizes the risk of ischemia and subsequent stenosis. And we should always assess regularly this kind of possibility. As Antonella said, the treatment options range from the conservative approaches such as dilation or stenting to more invasive surgical option. It depends, of course, on the extent and the severity of the stenosis. And finally, the multidisciplinary approach is needed in this cases, because the involvement of the pulmonologist, the intensivist, the ENT is really crucial for the correct management of this kind of patients. But still today, definitive pediatric guidelines are lacking. For example, guidelines about the follow-up after the endoscopic or surgical treatment. So maybe we should encourage clinician researchers to do something on this topic. Thank you for your attention from me and from Antonella from CC.
Thank you very much,
Thank you.
Giuseppe. Hi, thank you very much. We have a few minutes for questions now, and we have received some questions, a couple of questions about the first case. So I would like to encourage you all to send questions via the chat tool. And anyway, I have a question for Michele and Giulia. So the first question is, did you check the eosinophils between the time you stopped mepolizumab and you started the dupilumab? And it says that in some randomized clinical trials, dupilumab cause transient eosinophilia. And I wonder if the child had an initial transient worsening of symptoms after starting dupilumab or a consistent improvement. Michele or Giulia?
Okay, thank you very much for this question. First of all, after mepolizumab discontinuation, we found an increase of eosinophilia as expected. But eosinophilia didn't reach the level to exclude the possibility to start dupilumab. The clinical response to dupilumab was not only excellent, but very fast. So we didn't find a transient worsening of the situation.
Okay, very good. Thank you. And there's another question for you. This is from my friend Ali Ozdemir. I wonder, hi Ali. I wonder if the first case received oral treatment for a period of time in the course of disease. Did she respond to the treatment?
Okay.
Steroids.
Before starting dupilumab, she required many times short corticosteroids treatment that were repeated at least once a month. She showed a clinical response in the control of the symptoms. However, lung function worsening, and so we didn't find improvement of lung function after this short course of oral steroids.
Okay, thank you very much.
You're welcome. Thank you.
Thank you. So it's time to move. There are no other questions so far, so it is time to move to the third case. And the third case is from my group. Dr. Alberto Terminiello and Dr. Paolo Del Greco will show a case of persistent wheezing in an adolescent after Mycoplasma infection. So please, Alberto.
Can you hear my voice?
Yes, Alberto, we can.
Okay. So I'm here with Dr. Paolo Del Greco to talk about a persistent wheezing in an adolescent after a Mycoplasma infection. So we'll talk about a 14-year-old male with an unremarkable family history. He is born at full term with normal perinatality and no respiratory distress in the first days of life. He is up to date for immunizations for age with a normal growth and neurological development. In his clinical history, there is a sensorineural hearing loss in the left ear since the age of 3 years, with onset after a febrile episode and several episodes of wheezing during respiratory infections up to the age of 7 years. He was admitted in October 2023 in a provincial hospital due to a Mycoplasma pneumonia infection involving the left lung, and was associated also with the mucositis of the oral cavity. And he needed oxygen and oral antibiotics, and later developed asthenia, recurrent wheezing, exertional dyspnea, and dry cough that were treated with only salbutamol as needed.
Sorry, Alberto.
See?
Sorry, Alberto. Can you get closer to the mic?
Okay.
Can you get closer to the microphone? We can hear you, but there is some noise, some background noise. So.
Okay. Can you listen to me better now?
It is a little better, still noisy, but a little better.
Better, okay. So in December, he was sent in the emergency department by his general practitioner
because of wheezing and auscultatory silence in the left lung that was treated with salbutamol with positive effect, but reduced breath sounds persisted in the left base. It was performed a chest X-ray and was negative. Was reported as no radiological features related to acute events, and the budesonide and formoterol combination was started with mild improvement on symptoms. It has to be said that he has never performed pulmonary function tests before. And in May 2024, due to the persistence of these symptoms, a comprehensive cardiologic evaluation was made with normal results, except for a bicuspid aortic valve. The skin prick tests were negative for common aeroallergens, and the CT scan of the chest that was performed in a provincial hospital in adult radiology showed signs of fibrosis with the standard technique, and was then referred to our unit. In June 2024, he was evaluated for the first time on physical examination. The saturation of oxygen in room air was normal. No digital clubbing was noted, but diffuse inspiratory and expiratory wheeze was present on both lungs, with hypophonia at the left lung base and expiratory crackles. So was performed the first spirometry, which shows a mixed pattern with a severe obstruction that was initially responsive to salbutamol. And in the suspect of an asthma exacerbation, started the therapy with fluticasone and salmeterol and a cycle of oral prednisone, and we evaluated the patient a month later. In July 2024, there was a slight clinical improvement because he reported no more wheezing and cough as before. At physical examination, there were always persistent reduced lung sounds at left and a bit of wheeze on the left mid-upper left lung field. And spirometry was repeated, always with a mixed pattern, with no bronchodilation calculated on predicted values for FEV1, was added tiotropium, but further investigation were scheduled. So in August 2024, he was clinically stable, performed a sweat test that were normal. He's never been a mucus productive patient, by the way. On the blood tests, the immunoglobulin E were normal, and also the specific immunoglobulins E against inhalers, and immunological screening was normal. No immunological defects were found. And this is the last spirometry that shows a mixed pattern with a slight improvement in FEV1. And according to our radiologists, we performed an inspiratory and expiratory CT scan of the chest that showed on the left side an hypoexpansion of the lung, which appeared oligamic with signs of diffuse and ubiquitous air trapping in the expiratory phase, with grade 1-2 bronchiectasis of the left lower lobe and lingula, and with a slight thickening of the bronchial walls, and at the right side, some localized areas of air trapping in the upper and lower lobes. And this is the coronal view. Okay. So the findings described by our radiologist have been related to outcomes of bronchiolitis like Swyer-James syndrome. So we performed a time zero assessment before starting other therapies. He performed a polysomnography that was normal, a 6-minute walking test where he covered 57% of predicted distance with no big desaturations during the exam. We decided, according to our radiologist, to not perform a perfusion scan due to the typical radiologic pattern on CT, and was also performed a dietetic evaluation because of his BMI that we see is the second percentile. So in addition to his inhalers, started azithromycin 10 milligrams kilo given 3 times weekly, and monthly pulses of intravenous methylprednisolone. And I leave the discussion to Dr. Paolo Del Greco.
So can you hear me? So Enrico, can you hear me?
Yes, still a little bit noisy, but so.
I think it's maybe. Okay, so hello everybody, thank you for the invitation. So as my colleagues point, so we are talking about this Swyer-James syndrome. I mean, if you check on the web, and if you want to find Dr. Swyer, Dr. James, and Dr. McLeod, you see it's quite funny because it's difficult to find a picture of them, and because there are 2 doctors that in the 50s they described together in the same times, but they were in 2 different countries, Canada and England, these 3 patients with the same symptoms. So after they met each other and they decided to describe and then just talk about the same syndrome with their name. So, I mean, actually, if we just check on internet, PubMed as Swyer-James syndrome, we just find several cases presenting since childhood to adult. But I mean, if you want just to focus on the definition of the syndrome, we are in front of a rare condition characterized by hyperlucence lung lobe consequence of an obituary bronchiolitis. So immediately we jump on from several cases to a huge important group of disease, and we're talking about interstitial and in particular the diffuse lung disease. And if one just focus on the disorder related with the systemic disease process, and if we check in the group of small airway disease, we will find obituary bronchiolitis. So how is the pathogenesis? First of all, we have a trigger. In our case, in this case, but in general, most of the pediatric case, there is an inflammation trigger that are the infection disease. So RSV, influenza, adenovirus with several serotypes, Bordetella pertussis, tuberculosis, and in our case, we have the Mycoplasma pneumonia. So after this important inflammation trigger, we have destruction of alveolar wall, submucosal fibrosis, and vasoconstriction. So when we have vasoconstriction, we have 2 different paths. One is the airway limitation and obstruction of pulmonary capillary bed. The second one is the reducing arterial perfusion. So these 2 conditions spread the way to an inflammatory process that's going to cause obliteration of the small airways, alveolar hyperdistension and air trapping, reducing pulmonary vascularization and volume loss, and then hyperlucency. So about the symptoms, patients can have chronic cough, dyspnea at rest or during exercise, chest pain, recurrent lung infection, persistent wheezing, and failure to drive. As our patients actually. If you want to find some 3-4 items to recognize the syndrome, first of all, using the lung function. It's the classic, as Alberto said before, obstructive and mixed pattern in the spirometry. But also total lung capacity, so with the plethysmography may be slightly reduced if the patient is able to perform. Our patient wasn't able to do it. But if you want just to focus on the diagnostic criteria, on the imaging, first of all, unilateral loss of lung with hyperlucency in the chest X-ray, unilateral reduction in vascularization in the CT scan, and also sometimes associated with bronchiectasis, and unilateral loss of perfusion with technetium, so with scintigraphy. So just we said as we saw before. This slide is just useful because, I mean, sometimes we are in front of patients with the unilateral hyperlucence pneumothorax. So sometimes we have just to ask to ourselves, okay, but where is the problem? Is it on the left or is it on the right? So first of all, just ask if the patient is rotated, if there is artifact, if there is a problem in the thorax or scoliosis. So if just follow the flow chart, when we are in front of patients where we understand there is hair trapping, think about airway disease, hair problem, and so we can also have to think about Zweyer-James syndrome. Management, okay, so also following the approach of the diffuse lung disease, what my colleague said before, what should be and what also we try to have done. First of all, prevention of infection, so pneumococcal and influenza vaccination. Will be also amazing the RSV, as we know now we have this new nirsevimab, so it will be also another important stuff to use. Steroids, so steroids IV is maybe the most important therapy. Steroids, first IV with pulse dose of 30 milligram per kg for 3 consecutive days, and then also you can continue orally, or just as we have done with our patients, we started with 3 days IV in consecutive months. We can also use the inhaled steroids associated with the long-acting, or also use the immunomodulation and anti-inflammatory effect of the azithromycin. For sure, oxygen therapy in patients with chronic respiratory failure, and the chest physio in patients who has bronchiectasis. If we have patients with failure to thrive, nutritional program, and then surgery in patients with irreversible damage in the lung. So the take-home message of this case, for sure, not always, we talked tonight of this wheezing, also in the other 2 cases, so not always is asthma. We have to know, I think it's, I mean, we understand not only our case tonight. Also, the unilateral pathological lungs need diagnostic insight. A rare disease exists, so we have to study, we have to know it, and it will be also amazing to recognize it. And inspiratory and respiratory chest CT scan is helpful. First of all, to evaluate patients with suspected airway pathology, to identify hair trapping in patients with a normal inspiratory CT scan, and also to make differentiation between the 3 possible causes of mosaic pattern, so the small airway disease, obstructive vascular disease, and infiltrative lung disease. And also just remember, sometimes the unilateral hyperlucent pneumothorax could be a challenge. So it's important just to work in a team with a pulmonologist, with a pediatrician, and also with a radiologist colleagues. Thank you.
Thank you very much. There are no questions so far about this, but so just have a very small question. So could you add a comment on why we decided to go with pulses of methylprednisolone?
Sorry.
So
sorry.
Yeah, could you just make a comment on why we decided to go ahead with pulses of methylprednisolone? Just because the... Do you want me to say again? Okay, can you hear me better now?
Yeah.
Okay.
So, I mean,
so just a comment on the pulses, yes.
Yeah, okay, because I mean, if you check on the literature, actually, we are talking about a problem in the bronchioli, and I mean, also in the diffuse lung disease, the anti-inflammation objective is try to stop the progression, also the obliteral bronchiolitis. And actually, what is evidence is that anti-inflammation is going to stop the inflammation and the progress and spread of bronchiolitis. So we just follow the actually line guide, and we use the pulse therapy. The question is if we want to continue also orally in the same period, but actually the patient was quite stable and quite well. So we was thinking about the positive and negative effect of also steroids orally. Actually, we're just only following with 3 days IV for 6 months. I think now we are in the 6 months. No, maybe no. I think now we are in the 3rd month. Yeah, because it was August. Because we have several obliteral bronchiolitis this year. So we just continue to follow, and then we will see.
Yes, I mean, it was a recent disease. It wasn't stable for many years. I mean, it was just started a few months ago, right? So it was recent.
I saw him on June. We opened the hospital, and you see on August, and then we have done the CT scan. So I mean, it was something that, and it was okay. It was failure to try, but we didn't accept. We were thinking the classic asthma, but we didn't accept this kind of the CT scan. But as we said, in this year, we had in our hospital, I think not all year, also here, few cases of bilateral bronchiolitis post-infection.
And everything was happening under our eyes. So it was a new onset of a disease, and we decided to try monthly pulse therapy.
Okay, thank you very much. So I see no questions so far. Let me check. No other questions. So, I mean, anyway, it is time to close this very interesting VIPPN clinical case series session now. So I would like to thank all the participants and all the speakers, and also our society, SIMRI, for this very interesting session. So thank you very much, and see you all for the next session of the VIPPN clinical case series. Thank you very much.
Thank you.
Thank you, everybody. Good evening.
Good evening.
Thank you.
Good evening.
Thank you.